right. Well, that's wonderful. So like Dr. Beamer was saying, we met about a year ago, and I've been working with Dr. Mukadam down in Arizona. I'm a third-year medical student, and we're looking at the ICAN discussion aid. So first, a little bit about me and why I care about care that fits. So I grew up on a farm actually in eastern Montana before I started medical school. And I don't know if you guys are aware of this, but about 20% of the American demographic lives in rural areas. But about 5% of the physician workforce was raised in a rural area. So a really interesting thing, having been someone who grew up in a rural area, is that a lot of people don't understand what the day-to-day life is for folks like us. It becomes a really loud experience when you enter healthcare, because so few people who are clinicians grew up in rural areas. And my first experience actually with kind of the disparity of understanding of the day-to-day life of people from a rural area was when I was 9 years old. My mom, who's pictured here, passed away from heart failure, chronic condition, as a result of peripartum cardiomyopathy. And just looking at her, you wouldn't know that she had heart failure. But something that my family didn't know is the real risk of living an hour away from access to defibrillation. And something we didn't have was a physical address, which is actually a normative issue in rural America. You describe where you live by saying, I live 7 miles south of this mile marker. If you pass the railroad tracks, you've gone too far. And when you're contacting emergency services in 2005, that's a really unfortunate situation to be in. At any rate, so when I wanted or decided to go into medicine, I was really passionate about making sure that we understand how patients live and how that affects their experience of healthcare. And as I've been a medical student, I realized that it's not just people from rural areas, it's every single patient that we encounter has things about them that we don't understand, and that we should really be inquiring about. So that was what interested me in the ICAN discussion aid. And I know Dr. Beamer already gave an introduction of the ICAN discussion aid this morning, but I'll kind of give a brief overview here. 19 questions in the internal bifold, and asking, basic questions about satisfaction and burden in the patient's individual life, and then in their experience of healthcare. In addition to that, 3 free answer questions as well. So our study essentially was looking at the patients of a single primary care provider at Mayo Clinic in Arizona. So there were over 1,000 discussion aids that were filled out by 635 patients between April of 2018 and May of 2021. She had 678 eligible patients who could have completed the questionnaire during that, or during the discussion aid during that time. And so our goal essentially was to develop a model that predicted the most number of burdens, or really any statistically significant difference in burden between patients based on their clinical characteristics and demographic data. And our hope was to better understand which patients may benefit from ICAN's use, to enable its judicious use in resource-limited settings. So, we understand that some clinicians may not want to use the ICAN discussion aid in every encounter. So when it comes down to only wanting to, use one of these a day, who's the patient you should use it on? And then ultimately, we need to recognize the limitations of our work, which I'll talk about later. So this is the chart review that we did on these patients, looking at the chronic conditions most commonly treated in the practice, the number and type of medications the patients were taking, and whether those those medications were prescribed to them or if they were taken over the counter. In addition to that, we collected demographic data such as gender, the patient's age, and BMI. And what we did with the help of a wonderful statistician, Dr. Molly Klanderman, was make these decision trees, essentially that represents the statistical, it's a mathematical model that represents the statistically significant differences in patients with any number of conditions or combination of conditions. So if you look at the bottom left here, I've provided a key that shows what every leaf is. So I'll just walk through one of these with you. So the top says the average burdens in each leaf, and then we've got total burdens over the number of patients here, and then percent patients in the demographic on the key. And that translates up here to, if we just look at the overall patients in our demographic, we're looking at personal burdens, so the left side of the ICAN questionnaire. Overall, in our demographic, our patients have an average of 1.3 personal burdens, and that's 635 patients because we're looking at all of our patients. And then these patients make up 100% of our patient demographic, and they have 818 total burdens in that population. And then if we say the patient has depression, we find that depressed patients have 2.3 average personal burdens and make up 22% of our patient demographic. And if we say they're depressed and under the age of 38, they have an average of 4.6 personal burdens and make up 2% of our patient demographic. Whereas if we go down the left side of this tree, they're not depressed, they're over the age of 63, and they don't have generalized anxiety. They have 0.57, average personal burden, so far less at risk in that respect. Clear that. So in addition to that, with this type of analysis, a variable importance plot is generated. So these are things that do have a statistically significant effect on the number of burdens that are reported, but didn't wind up in the overall model that was created, the decision tree that was created. So in addition to depression, age, generalized anxiety, and body mass index, number of prescription medications, hyperlipidemia, anxiolytic use, hypertension, statin use, antihypertensive use, obstructive sleep apnea were all considered important, with decreasing importance when we're looking at obstructive sleep apnea, number of over-the-counter medications, and insulin use. And then on the right side of the discussion aids, it talks about healthcare burdens. So we looked at what patients were most likely to have, or what risk factors were associated with increased burden. And what we found in terms of the decision trees is that we really only found people with a BMI of over 26 were patients who had statistically more healthcare related burdens. So about twice as many as patients with a BMI less than 26. But in addition to that, we have the variable importance plot, which showed hypertension, antihypertensive use, number of prescription medications, hyperlipidemia, and obstructive sleep apnea were also considered important, but much less important than BMI. And then finally, just an overall decision tree showed very similar results as a combination, in that depressed patients have 3.3 average overall burdens, whereas patients who aren't depressed with a BMI less than 32 and age over 61 have less than 1 reported burden, which is significantly less than the average in our demographic. So when we think about this and kind of how this fits into the overall model of minimally disruptive medicine. Just thinking about that, the patients that we're proposing are most burdened on ICAN are the people who are younger, have more comorbidities, who have greater BMIs, and these are the types of things that we do think of when we think of patients who are going to have increased workload and decreased capacity. Because, as you think, patients who are younger, they've got a lot going on in addition to managing these chronic conditions. And if they're depressed and overweight, and in addition to dealing with all of this morbidity from these chronic conditions, they have a decreased capacity to handle all of that work. And so our proposition would be that in a resource limited setting, it would make sense to try to use ICAN out on patients who are younger and who are dealing with these comorbidities. So some limitations of our study is, of course, we're at a single center where we're dealing with a single primary care provider. Another thing that was interesting in how we did our chart review was that it was performed at one point in time and using the problem lists at that point in time. And that was done last summer, whereas these patients filled out these discussion aids over a 3-year period. So the problem lists may not have been 100% accurate, but given that we're dealing with chronic conditions, they probably were relatively accurate. Another thing is that the statistical analysis we used sacrificed accuracy in favor of interpretability for clinicians in terms of writing on a manuscript and trying to express this data. But another analysis called a gradient boosted machine would actually be preferable in creating an additional overall model. And then the other thing is that the demographic and clinical data that we presented is not comprehensive. It would be nice if we were to do this project again to just take, every condition from the patient's problem list and represent that in a model. But we looked at the chronic conditions most commonly treated in practice. In addition to that, we neglected some demographic data. Important ones would be race and income. So socioeconomic status was not represented in our model. But cautious conclusion would be that younger patients with mental illness and chronic illness may be a target audience for its use in resource limited settings.